Hi everyone, my name is Angela Nye. Today I'll be sharing key takeaways from a 2020 consensus statement jointly published by the American College of Radiology and the National Kidney Foundation. This article focuses on a topic that most radiology professionals encounter: how to safely use intravenous iodinated contrast in patients who already have some level of kidney disease. It's a subject that has caused confusion and hesitation for years, and I think the findings of this article help us bring some clarity and confidence back into contrast decision making. As someone who works directly with imaging patients, I find this topic especially relevant because we're often the ones balancing diagnostic need against patient safety. For decades, radiology staff have been taught to be cautious when using iodinated contrast, especially in patients with chronic kidney disease. The fear of causing kidney injury often led to exams being delayed, denied, or replaced with less optimal alternatives. While the intention was to protect the patient, these delays sometimes led to diagnostic errors or missed findings. The authors of this study wanted to challenge these long held fears by re examining the actual risk of kidney injury caused directly by contrast. They emphasize that evidence has evolved and our practices need to evolve with it. Personally, I've seen this hesitation play out firsthand, where a patient's CT with contrast was put off because of a low eGFR, even though the diagnostic benefit would have outweighed the risk. This article represents a joint effort between radiologists and nephrologists, two specialties that sometimes view contrast use differently. Their goal was to establish a single, evidence based standard to help all clinicians make consistent and safe decisions. The statements in the article are officially endorsed by both the American College of Radiology and the National Kidney Foundation. That endorsement gives this document a lot of weight across the imaging community. It's also important to note that these statements apply only to intravenous contrast used for CT exams, not for intra-arterial procedures like coronary angiography, which involve different risks. That clarification alone can help prevent a lot of unnecessary confusion in day-to-day clinical practice. One of the biggest contributions of this paper is clearing up the terminology. Historically, the term contrast-induced nephropathy was used to describe any kidney injury occurring after a patient received contrast. The problem is, many of those cases were never actually caused by contrast at all, so the authors introduced two key terms: CAAKI and CIAKI. CAAKI stands for Contrast-Associated Acute Kidney Injury, meaning the kidney injury happened after contrast was given, but may or may not have been caused by it. CIAKI stands for Contrast-Induced Acute Kidney Injury, meaning there's clear evidence that the contrast itself caused the damage. Most of the past research failed to separate those two ideas, which made the risk of contrast seem much higher than it really is. I think that this distinction is one of the most useful takeaways from the paper. It encourages us to use more precise language and avoid labeling every rise in creatinine as contrast induced. To determine the real risk of CIAKI, the researchers reviewed multiple large observational studies published between 2013 and 2019. These newer studies used proper control groups, meaning they compared patients who received contrast with similar patients who did not. By doing that, they could see how much kidney injury actually resulted from contrast itself, rather than from other medical issues happening at the same time. They also organized findings by kidney function, using eGFR levels to categorize patients. This allowed for a much more accurate picture of risk rather than the older one size fits all approach that made contrast seem dangerous for nearly everyone with kidney impairment. Here's where things get really interesting. The data showed that for most patients, the risk of true contrast induced acute kidney injury is near zero. For patients with an eGFR of 45 or higher, there's virtually no measurable risk. For those in the 30 to 44 range, the risk is estimated around 0 to 2%. Only patients with severely reduced kidney function, below 30 milliliters per minute per 1.73 square meters, showed any meaningful chance of risk, and even then, results were inconsistent between studies. That tells us that the vast majority of patients can safely receive iodinated contrast when it's clinically necessary. As a technologist, this gives me confidence that I'm supporting evidence based care when I proceed with contrast exams after appropriate screening. The article emphasizes that screening should be based on eGFR, not just serum creatinine levels. The most reliable predictor of kidney function is the estimated glomerular filtration rate, which gives a clearer picture of how well the kidneys are actually working. We should check the eGFR for patients who have a known history of kidney disease, a previous acute kidney injury, kidney surgery, or albuminuria. Diabetes is sometimes considered, but the authors found it isn't an independent reason to screen. This helps simplify our workflow by focusing on patients who truly need screening instead of over-testing everyone. In my experience, having clear criteria like this also helps reduce unnecessary delays before CT scans. The next question is when to give preventative hydration. The authors recommend using intravenous normal saline before and after contrast administration in patients with an eGFR below 30 or in those with an active acute kidney injury who are not on dialysis. For patients with an eGFR between 30 and 44, it's optional and can be decided based on other risk factors or recent kidney issues. Oral hydration hasn't shown strong evidence for preventing injury, and medications like N-acetylcysteine are no longer recommended. The best protection is simple, adequate IV hydration. This is something we can help facilitate by coordinating with nursing and ensuring the patient is well prepared before the scan. Medication management is another key aspect. The article advises holding non-essential nephrotoxic medications before and after contrast use when possible, things like NSAIDs, diuretics, and certain chemotherapy agents. For metformin, it should be stopped in patients with an eGFR below 30 or those who develop acute kidney injury, since there's a risk of lactic acidosis. For patients on ACE inhibitors or ARBs, the renin-angiotensin system drugs, it's more controversial, but it may be wise to withhold them for 48 hours before and after contrast in high-risk situations. The main takeaway is that medication timing and coordination matter, but we shouldn't overcomplicate it. And importantly, the authors note that dialysis schedules should never be altered just because a patient received contrast. That practice doesn't provide any proven benefits. The article also covers some specific patient groups. For patients with a single kidney, whether from surgery, donation, or congenital reasons, management should be based on eGFR, not kidney count. As long as kidney function is adequate, contrast can still be used safely. For patients on dialysis who still produce a small amount of urine, they should be treated as if they have an eGFR under 30. And for pediatric patients, there's not much direct data, so the authors suggest cautiously applying the adult guidelines until better evidence is available. I think this section helps reinforce the idea that we should individualize, not generalize, our approach to contrast safety. The authors emphasize that modern low osmolality contrast agents are much safer than older formulations. The real danger now isn't the contrast itself, it's delaying or denying necessary imaging because of outdated fears. By following these updated guidelines, radiology teams can make decisions confidently using eGFR based screening, hydration when needed, and clear communication with referring providers. In my own clinical setting, I've seen how collaboration between technologists, radiologists, and ordering providers make a huge difference. When everyone understands the evidence, the patient gets the care they need faster and safely. This slide summarizes the major points of the 2020 consensus. It compares ACR NKF guidelines with other past recommendations and shows where they align. It's clear that the new guidance focuses on individualized care, simplified screening, and hydration as the main preventative measure. These recommendations replace fear-based restrictions with data-driven confidence. As someone working in radiology, that shift is empowering. It means fewer canceled scans and more timely diagnosis for our patients. To wrap things up, the key takeaway from Davenport and colleagues is that the risk of true contrast-induced kidney injury is much lower than we used to think. We shouldn't automatically withhold contrast when it's clinically indicated. Instead, we should assess kidney function accurately, hydrate when necessary, and communicate clearly with the healthcare team. These are small steps that make a big difference in patient outcomes. For me, this article reinforces how evidence-based practice helps us balance patient safety with diagnostic accuracy.